Vein of Galen aneurysmal malformation of choroidal type, presented to you by Alex Bernstein, Sri Paramasivam and Yasunari Nimi. We present a child born at 38 weeks of pregnancy and was delivered emergently by C-section due to fetal distress. The child at birth had congestive heart failure and cranial ultrasonogram revealed vein of Galen aneurysmal malformation. The child was then transferred to our institution, and on day 2 of life, the cardiac condition worsened and MRI of the brain revealed complex choroidal type vein of Galen malformation with feeders from the right side as well as from the midline. The child also had pre-existing ischemic damage to the brain, mostly confined to the right parieto-occipital region. The child was taken off for emergency endovascular embolization on day 3 of life. Left vertebral artery angiogram revealed the complex choroidal type vein of Galen malformation. 1.2 FM MIGIC microcatheter is advanced selectively into the posteromedial choroidal artery, and NBCA embolization is performed under systemic hypotension. The microcatheter is retrieved at the end of embolization fairly quickly. Additional feeders are selectively catheterized, and endovascular embolization is performed using NBCA under systemic hypotension. Note here, the actual size of the vessel is not visualized with the angiogram due to high flow washout, while NBCA embolization reveals the actual caliber of the vessel. The microcatheter is retrieved quickly. The control angiogram reveals significant reduction in the flow to the malformation, and now the guiding catheter is moved to the left common carotid artery that reveals the fetus arising from the anterior cerebral artery, which is super selectively catheterized using another MAGIC 1.2 FM microcatheter, and NBCA injection is performed under systemic hypotension. One can see the glue infiltration into the fistulous location with minimal escape into the vein. With minimal reflex, the injection is stopped and the microcatheter is retrieved quickly. Control angiogram of the left common carotid artery reveals additional feeders from the anterior cerebral artery. Post-embolization angiogram of the right common carotid artery revealed no significant supply from this vessel to the malformation. Following embolization, the congestive heart failure improved and the child was discharged home. The child continued to develop with mild developmental delay, and second stage embolization was planned at 6 months of age. MRI done just prior to embolization revealed significant reduction in the size of the malformation. Angiograms of the left vertebral artery, right common carotid and left common carotid arteries revealed significant reduction in the size of the malformation with diminished size of the fetus supplying the residual malformation. Superselective catheterization of the anterior cerebral artery from the left common carotid artery was performed, and NBCA embolization was performed to one of its feeders supplying the malformation. You can see here fine network of vessels that anastomose with each other before draining into the malformation. Additional superselective angiogram of the anterior cerebral artery is performed, and we do progressive angiograms as we advance the microcatheter more distally to understand the complex nature of the malformation. Once the microcatheter is placed more distally, close to the fistulous location, NBCA embolization is performed. With the reflex, you can see additional feeders being filled, and the microcatheter is retrieved in a quick time. Here again, additional feeders of the anterior cerebral artery are superselectively catheterized, and NBCA embolization is performed with the distal location of the microcatheter. Additional feeders of the anterior cerebral artery are selectively catheterized, this time past the splenium. The feeder entering into the roof of the third ventricle is superselectively catheterized, and NBCA embolization of the feeder is performed with excellent obliteration of the fistula in the roof of the third ventricle. Control angiogram of the left vertebral artery reveals significant reduction in the flow to the malformation. The child continued to develop with mild developmental delay, and at 1.5 years of age, an MRI was performed that revealed significant reduction in the flow to the malformation, and a third stage planned embolization was performed. Right Carmen and the left Carmen carotid angiograms revealed no significant supply to the malformation from these vessels. The fetus from the anterior cerebral artery has been cured. The left vertebral artery angiogram revealed residual supply to the malformation from the right posteromedial choroidal vessels. These vessels were super-selectively catheterized using Magic 1.2 FM microcatheter over a Mirage microguide wire. Super-selective angiogram revealed the complex nature of these feeders. Some of the connections are made by angiogenetic network of vessels. Super-selective catheterization of these small feeders needs a fine interplay between the microcatheter and the microguide wire. As you can see here, the microcatheter is in front of the microguide wire. An attempt is made to forward the microguide wire in front of the microcatheter. You can see the whole vessel buckling and the microcatheter is being pushed backwards. With continued attempt, the microcatheter is significantly pushed backwards, and then a forward pressure on the microcatheter advances the microcatheter across this turn into a more distal location, but into a smaller normal branch. Now the microguide wire has taken this turn. Taking advantage of this location of the microguide wire, the microcatheter is pulled back, and gently the microguide wire is advanced and redirected to a more desired location. Now, as the microguide wire is in front of the microcatheter, it is gently redirected into the desired location, and the microcatheter is gently threaded forwards to take that next turn. As you can see here, the wire is advanced and the microcatheter follows it, and it is pushed to the desired location. Super-selective angiograms at that location reveal the complex fine network of vessels feeding the fistula. NBCA embolization of the feeders are performed with nice infiltration of the glue into the fine network of vessels. The microcatheter is retrieved gently, and the control angiogram of the left vertebral artery reveals minimal residual flow in the malformation. The child continued to develop with mild developmental delay. MRI performed at 2 years of age revealed normal development except for the right occipital region due to neonatal ischemia. The rest of the brain growth was normal. Subsequently, the control angiogram was performed that revealed near complete obliteration of the malformation with minimal residual flow happening through a fine network of angiogenetic vessels supplied by the choroidal vessels. Here with the left vertebral artery angiogram, you can see minimal supply to the fistula. Super-selective catheterization of the fetus supplying the fistula was performed, and as described above, a fine interplay between the microcatheter and the microguide wire was done to advance the microcatheter more distally closer to the fistula. Super-selective angiograms were done at various locations, and the microcatheter was advanced more distally closer to the fistula. Once the desired location was achieved, NBCA embolization of the fistula was performed. Post-embolization angiogram of the left vertebral artery revealed near complete obliteration of the vein of Galen malformation. Following embolization, the child continued to develop with mild developmental delay, and further follow-up of the child was performed using clinical examination and MR angiography.